So I want to welcome you to this conversation on our healthcare. Thanks so much for coming. Proving again that Cornwall is one of the most punctual places on earth. The fact that we can start practically on the moment. And I'm Jeremy Brecker. I live in the northern end of town. This gathering was organized by a group of residents from the Cornwalls who think everyone should have access to health care they can afford. Just as we don't know whose house will catch fire, so we have a fire department for everyone, we don't know who will need health care, and so we need to make sure that it is available to everyone. Our first speaker is going to be Ted Doolittle, Connecticut healthcare advocate with a long resume in various aspects of healthcare policy and administration. But more important than that, Ted grew up in Sharon and attended this very Cornwall Consolidated school. So, local boy makes good. And our second speaker will be Janet Carlson, who's Executive Director of Health Pathfinder, formerly PharmaCare, a nonprofit company with its office in West Cornwall. I'm sure many of you have seen it there. It's the railroad station. It's a nonprofit company that assists people to get access to health insurance, medicines, and healthcare advocacy. So basically, we couldn't have two people more able to guide us on the subject we're going to be talking about tonight. We're hoping that together, all of us can explore two questions. What healthcare do people in Cornwall and the surrounding area need? And people are invited to speak up and tell stories and give us information, share information about their experiences and their friends and neighbors' experiences. And the second is, what do the debates over the national healthcare system, and we're having those bombarding us in the news yet again, what do they mean for whether we get what we need? We've asked our two speakers to talk for a total of 20 minutes, so we'll have plenty of time for questions and discussion. Okay?
Don? Yep. Thanks, Jeremy, and it's great to be back in the Cornwall School. I was trying to look on the mental map. This is not that far from my 4th grade classroom. Miss Baum was my teacher, and there was a weather thing, that I was supposed to monitor every day outside. I had to go out and record whether it's cirrus clouds or whatever the clouds were. So it's good to be back. I don't have a weather report today. It rained an awful lot in Hartford today. Anyway, it's good to see everybody. So Jill Cutler was kind enough to send me a variety of questions that the group had come up with. So I tried to do a little research specific to Litchfield County and walk you through some of the questions. Make sure I understand this quicker.
Just the center of that round. Right.
Center one.
Yep. Point at that thing. Yep, there
Okay.
you go.
So the most important part, I think, of the speech is of this evening for my office is this first couple of minutes, because whenever I have a group of citizens and residents of Connecticut, I want to make sure you all understand what the Office of the Healthcare Advocate is. The Office of the Healthcare Advocate is an independent state agency. I'm appointed by the governor, but it's a separate state agency. We're staffed, the important thing that you need to know is that we're staffed by attorneys and nurses that can help you or a loved one who is having problems accessing health care, particularly if you're having insurance problems. So if you're having a billing dispute with an insurance company, they won't cover something. We have a staff of nurses and attorneys and other professionals who can help you for free. And we can't win everything, but if it can be won, we've got to you've got a doggone good chance of doing that. So keep that in mind for your own lives, lives of your neighbors, families, friends. The agency's not well known enough, and I know that it's information that somebody in this room can use. The last, when we break for questions, I will have a slide up there that has our website and our phone number on there, and so please don't hesitate to reach out. We handle expensive and life-threatening situations like cancer with a chemo being denied. We also can give you just coaching. If you just have a question, many of our calls can be taken care of in just a few moments with one of our experts on the line. So don't hesitate to reach out. Not many states have this type of resource, so please avail yourselves of it.
Can you feel free to speak up a little bit?
I can do it. I'll put it on.
Thank you. To speak a little louder? Or?
Yes, I will do.
Thank
There we go. Voice of God, Morgan Freeman. So this is your slide, Janet.
This is my part.
Yeah.
Okay, so Jeremy was kind enough to describe a little bit about what Health Pathfinder is. A lot of you knew it as Pharma Cares. It was interesting because I came from the pharmaceutical industry, so I thought when I set up a nonprofit to help people that Pharma Cares, like someone in pharmaceuticals actually cares. It just didn't ever play out right. So as much as I wish that it had, it just didn't. I'm still a ex-pharmaceutical person who does care, by the way, but Health Pathfinder made a lot more sense, and the response has actually been very good. It's just more logical, I think. But yeah, he was kind enough to describe what we do. So there's three things. We help people find health insurance, affordable health insurance, and we'll keep working until we do. And I've had 2 people out of 6,104 who didn't like what they got. One lady made several $100,000. I'm not sure what the beef was, but that's her gig. And one lady didn't want insurance that she had to pay $13 for. I thought that was a pretty good deal. But again, not my place to say. Everybody's got their own experience. So 2 out of 6,104 is actually a pretty good record. So if you need help with health insurance, getting medicines, that means long-term medicines, short-term medicines, whatever other kind of medicines you need, we can help you get that. There's a lot of different ways to do it. Healthcare advocacy is the third thing. So a lot of people have unpaid health bills, doctor's bills, hospitals bills, whatever. If you can't pay co-pays, if you need help, you come and see us. A lot of times I go to OHA, the Office of a Healthcare Advocate, if it's just too big. So there are circumstances where we had people who had very big problems. There was never a situation that OHA did not help, and help in an amazing way. So I know they don't get nearly enough credit. They should have tons of credit. I think what you saved the state $81 million or something ludicrous like that, and in a very short period of time. So they're to be lauded, and they're amazing people, the kindest people. So, okay. We're going to talk a little bit about the insurance status. We're going to be talking, looking kind of at a 60,000 foot view. So we're going to look at it from a state viewpoint and then look at different counties. We'll be looking at healthcare provider status, and again, state versus several counties, and snapshots. It's important to look at how are other countries doing this, providing healthcare for their citizens, and kind of why aren't we? And then we'll talk a little bit about a listening tour that Ted and his group over at the Office for the Healthcare Advocate is doing. So they've been going around Connecticut talking to people about healthcare, health insurance, and find out what the needs are. And people are telling their stories. These are the kind of things that are going to lead to changes in our laws and can impact, Connecticut down the road. So it's important to share those stories. Okay, let's talk a little bit about insurance status. And everybody can hear me okay? Can everybody see this okay, or should I turn out lights?
Turn some lights. Speak up
Okay.
a little bit, or
Yeah. My mother always told me to shut up, so it's hard to hear you talk louder. Okay, so let's just talk about the percent insured. In the United States right now, it stands at about 8%. That is because of the Affordable Care Act. There's no other reason. Because if you look at this chart over a period of time, we were rolling along, between 12 and 15% uninsured. But you can see how much it drops. So if you take a look at Connecticut, which is the top one, versus Litchfield County, which is the red, we're right around that 8% at the state level and a little bit lower in our county. So we've had the benefit of people who've worked very hard in our county to get people signed up. And like I said, 6,104 is how many people we've signed up to date. And if you have any questions on these slides, don't hesitate to ask. I'm the kind of person you can butt in on and I don't care. Yes, sir.
So I just want to point out that there's Jill's group had some questions about how does Litchfield County compare to other areas in Connecticut. So I picked Windham County. There's no perfect analog to Litchfield County, but Windham County is in the northeast corner. It's a quiet corner. I thought it was the closest county. There are some differences, but that's why you're seeing Windham County and Connecticut, because folks wanted to have an idea of how Litchfield County compared to other rural areas in Connecticut.
All right, so if you look at the percent insured by income, this really bothers me. It's the poor people who are still uninsured. So if you look at the numbers, if I'm not mistaken, Ted, it's 138% or lower is qualified for Medicaid, if those numbers are still holding. So you have a tremendous amount of people who are at or below 138% of poverty level, which is nothing. I mean, for a single person, I think it's $16,388 or something crazy like that. Why are these people not insured? And that really bothers me. I know some people are younger people, and they don't think they need insurance. Completely incorrect. I can talk to you about the guy who came to my office with a nail through his hand, wrapped up, and said, "Hey, can I get insurance?" And I'm like, sure. Fortunately, I could sign him up in about 15 minutes, but the poor chap had a nail through his hand. So, and I had people call me in the emergency room, "Can I get insurance?" I said, "Well, where are you?" And usually it's in the emergency room. And he said, "Well, I have 2 broken arms, so my mom's gonna have to talk to you." So, and that can happen to you at any age. So, for people who are younger, you're not immune. And it does concern me that so many people who don't have the money, they can be signed up for Medicaid. I have never heard anybody complain about Medicaid who has it. And not in the state of Connecticut. New York may be a different situation. I think there are longer lines, less providers. That is not the case here. The care in Connecticut has been wonderful. Now what's interesting is, if you're below 400% of poverty, and look at Litchfield County, we're pretty low. So, I just find that concerning still, that there's a lot of very poor people who don't have health insurance who could be getting it free. And Medicaid, we all pay for Medicaid. Medicaid just doesn't show up out of nowhere, we all put into it. So if someone needs to get the help's available, and it does make a big difference. Okay, this troubled me even more. So if you look at all races, and again, for the state of Connecticut, you're right at about that 8% mark. We're less in Litchfield County. We're probably about, like that 7.5% uninsured as a whole, but it's poor Hispanics and poor Blacks that are uninsured. And I know I did an event over in Winstead, I believe, and it was at the mobile food station that they have that is amazing. What was interesting, there were hundreds of people online. And out of those hundreds of people, I was going up and saying, and I had a Spanish translator with me, and I would ask people if they needed help with healthcare. And there were people who would start looking down before I got to them. And the Spanish translator would talk to them, and he said, "We need to keep moving." He said, "That guy's not going to talk to us." And so at first I would say, "Well, why?" And he goes, "Come on, Janet, you know why." So I think that's terrible. But there are also places to get care, even if you are undocumented. So there's Volunteers in Medicine, there's several other places that will provide free care, no questions asked. No questions asked. So if anybody knows of anybody, Jane Sellery is right here. She's our social services person. I will make sure she has all that information, because that kind of stuff should be shared. But again, if we have to work together, if there's people that that don't have health insurance, that need it, get them to Jane or call me, and we can make sure to take care of them. If anybody in Cornwall is uninsured, shame on us. Shame on us, because we will help them. Okay, so let's look at the coverage status, Litchfield County versus Windham County, and the total population. So when you look at the Affordable Care Exchange, in our version it's Access Health CT. Pretty much everybody's heard of that, right? There's about 4% in Litchfield County that are signed up through the exchange. There's about 15% that are on Medicaid. About a quarter of our population is on Medicare. I guess that doesn't surprise anybody too much. There are uninsured, about 8%. And then about 50% get their insurance through their employer. And that's pretty standard too, across the country. So those are the numbers there, and you can compare it versus Wyndham. They signed up less on the exchange, a little bit more on Medicaid, about the same on Medicare, about the same uninsured, and about the same going through an employer. So those are pretty standard numbers across the state. And we've been very active here, getting people signed up, whether they're going through the exchange or Access Health CT, whether they're getting signed up for Medicare or Medicaid. So there's help for any kind of insurance that you need at any time you need it. Any questions on that? Good. Okay, let's talk about health behaviors. I thought this was pretty interesting. We looked at overall Connecticut, Litchfield County, and again, Wyndham County. So we have access, I don't know how easily you guys can see this. So I'll just read them for you. Access to opportunities to get, exercise. So in Connecticut, it's a pretty high number. Obviously in Litchfield County, it'd be a pretty high number too. The obesity rate is pretty upsetting. It's about 25% of people in the state of Connecticut and around that in Litchfield County as well. A little bit higher over in Wyndham County. The adult smoking rate, 14.9. We're lower at 17.2, which is great. Wyndham is a little bit higher. Alcohol during driving, 32% in Connecticut, 29.5 in our county, a little bit higher in Wyndham County. Excessive drinking rate, 19% in Connecticut, a little bit lower here, even lower in Wyndham County. Physical inactivity, about 21%, we're at 19.7%. So whoever is not exercising, we gotta get those numbers up. And sexually transmitted infections, I thought this was interesting. 0.36, we're at 0.12, and Wyndham County is at 0.21. So we may be drinking and not exercising and eating, but we're not practicing unsafe sex. So I'm very proud of us. Okay, Ted's gonna talk a little bit about the healthcare provider status.
Okay, so this slide shows the key one really to understand most easily is the red bar, and this indicates how many doctor's offices we have per 10,000. You see in Connecticut the average is 7.6 doctor's offices, and then Litchfield over here at 7.6 as well. You see that for all ambulatory care establishments, so that's doctor's offices, but also other care settings like clinics and so forth, you see that Litchfield County is not too far off of the statewide average. Wyndham County is over here. They have fewer doctor's offices, fewer ambulatory care settings. A lot more of them, in other words, have to drive even further than we do from up here in Litchfield County. And this refers to primary care physicians, how many primary care physicians there are. You see this orange line is the US average, and then this is Connecticut here. So there's more primary care physicians in Connecticut, but then when you look at all the counties, you see that Litchfield County is below some of the other counties. And that's again telling you that folks might have to drive further here to get primary care. We are a little better off than Talon County and Wyndham County. Talon is over right near, that's where Yukon is. And so those are rural counties also. But as you would expect, it's a challenge for an area like this to have easy access to primary care. So Jill also indicated there was interest in discussing comparing our system to other nations. I'm not a huge expert in this area. I know a little bit about it. So I just picked out several of our economic competitor countries, you might say, right? The wealthy countries around the world to describe a little bit about their healthcare systems and how they work. There's some differences and there's some similarities. So in Japan, like here, most receive health insurance from their employer, If you don't, you have to sign up. I think they do it through the post office over there. The premium is determined by income for everybody. So they have a progressive, let's say, way of collecting the money. They regulate the prices, and you will see that a lot of countries do that. We don't do so much of that here. It does happen a little bit, especially there's some price regulation in Maryland in particular that's been going on for quite some time, and they're expanding that. And actually that will probably expand to other areas as well. The patients in Japan actually have to pay out of pocket for, in some cases, for a substantial amount of their care. So it's not that all the other countries have totally free care. It's not uncommon for other countries to have to pay out of pocket costs. And so the United Kingdom, obviously very famous for its health care. It truly has what is almost a socialized medicine system. And by that I mean they have a system called the National Health Service that actually owns the hospitals. And the doctors are typically employees. There are some doctors there that aren't NHS employees, but most of them are. And the services are free. And that is similar to parts of our healthcare system, notably Medicaid. I don't know if folks are aware, but Medicaid never, across the nation, never has a copay. Sometimes you have problems getting access to care because the doctors won't accept it. Sometimes items might not be covered, but the things that are covered in Medicaid, are free. Same in the UK. And how do they fund it? They fund it through their taxes. If you remember back in Japan, they were paying through their employers. Here, they pay for taxes. Some people go up from that sort of base level of care and buy their own private insurance. So there is some private insurance activity in Great Britain.
Ted, what can you pay extra for? What would you pay extra for?
A private room in a hospital, or to perhaps jump in line for your, you'd be waiting 6 months for your hip replacement, but if you want to pay up front, you can probably get it done quicker. So you can get, you can move to the front of the line, or you can get some additional services. Some things that might not be covered as well, you might be able to secure on your own or through an additional insurance plan that you buy for yourself. So Germany, interesting story, but this started under Bismarck. They were trying to make sure that the communists didn't get a foothold in Germany, and as a reaction, and this is what happened in the US as well too, they started a national insurance plan to cover laborers, and it gradually expanded over the years throughout the 2 world wars and so forth. It just gradually expanded to cover all the job sectors. Again, interesting that there is a link to your work. Although if you don't get it through work, you again, as in Japan, you sign up. I think in this case through the towns. I'm not sure, but they do have insurance companies in Germany. Not all countries do have insurance companies, but a fair amount do. But these are nonprofit insurance companies, and they can't. They're told what they need to cover. So it's much more regulated there. The German workers contribute about 15% of their salary into the sickness fund. Again, premiums based on income. Canada, some of you might be familiar. They're with it. The system's called the NHI, National Health Insurance. It's financed through general taxes. It's run by the provinces. It's financed by the federal government, but it's run by the provinces. And that's why it mentions it's a single payer system there, because all the money comes from one source. Again, minimal copays, no restrictions on physician choice there. So that's a little bit of food for thought. You might have questions during the question session. I just wanted to, these are some of the highlights, if you look back for the past 10, 15 years of what's going on and look toward the future. Right now, we all know the Obamacare is still in place. it's under assault every day. I often feel as a new executive order comes down, I feel like I'm a fly on the wall at Mount Vernon in 1999, and George Washington is lying there on his bed, and every time a doctor comes, they say, "Oh, let's bleed him, you know, and let's get some Spanish fly on him to get the blister, to get the bad, you know, fluids out of his body," and so pretty soon he weakens and dies after having been bled of a gallon of blood, as I think many in this room would, right? So I often feel like, you know, Dr. Trump is here now, and then Dr. Ryan, Dr. McConnell, and they each have a prescription that is not alone fatal, but after a few periods of time, it becomes difficult. You've heard about the bare counties out there where people are not having any options. There are no bare counties. A bare county is when nobody is participating, no insurance provider is participating in the Obamacare exchange. There are no bare counties. We have 2 carriers, which is more than 0, obviously, but it's not a ton. And they both of the companies are pretty committed to Connecticut. I think we're lucky in that regard. I'm not saying they're, you know, sweethearts, but they have bent over backwards to try to make this happen. We see Connecticut is a high healthcare cost state. The U.S. has very high healthcare costs, highest in the country, in the nation, in the world by far, and Connecticut is among the highest. I'd say we're in the top 5 in even our high-cost nation.
Weren't we 2/3 higher than the other countries? I mean, we had a chart that we did in a previous discussion, and you know, like of all the countries, you know, like all the industrialized countries, our care was almost the worst care, and it was 2/3 more expensive than
Oh,
any other
Janet,
country.
you're being so negative. No, it is true. The chart she's referring to shows that the per capita healthcare cost in the U.S. is about $10,000. That's how much it takes to, on average, to take care of an American. Now, you know, my little son who has, you know, an ear infection, that's a $300 hit. But if somebody on our block has a cancer diagnosis, you know, that becomes a $500,000 family pretty quick. And so the average is $10,000. The average in our economic competitor countries, like Japan, Germany, Canada, is about half that. So they're at 5,000 and under. The other nation that is relatively high cost is Switzerland, and Switzerland's a special case, also a small country, but that's relatively high cost as well. But Jan's point is right. We pay twice as much as our economic competitors. That's why Warren Buffett has said that medical costs are the tapeworm of American economic competitiveness. It's just growing too fast and becoming unsustainable. And I'll touch on that a little bit later when we talk about our Connecticut Speaks Out on Healthcare Cost project. And important, there's a lot of drivers in the cost in this country, and we can talk about it. Part of it is Janet's fault because it's pharma, but the also important is provider consolidation. If you drive down 44 to come into Hartford, you will pass several strip malls that have Hartford healthcare clinics. Those are affiliated with Hartford Hospital. Hartford Healthcare is a name for Hartford Hospital's relatively new corporation, right? So consolidation, they're buying up or merging with practices all over the place. That gives them tremendous market power. And Hartford Healthcare has become a very large corporation indeed. Yale is also extremely large. They're both very aggressive financially. I would say Yale in particular is known for just being really, really tough to get them to relinquish any coins. Right now, I don't know if folks are aware, but Anthem, which is the largest insurance carrier by far in the state, is having a contract dispute with Hartford Healthcare. And the contract ended on October 1st. So I'm covered by Anthem. And as a result, I no longer can go to my primary care physician, actually. And my urologist also is out of network, at least for the time being. You know, it's hard for your heart to bleed too much over Anthem versus Hartford Healthcare. But if there is a dog in the fight that you want to root for, it is the carrier, because this is a dispute purely over price. And Anthem doesn't want to pay the Hartford Healthcare prices. Hartford Healthcare is banking on the fact that they're so big that Anthem's just going to have to sign on the dotted line.
Anthem is an extraordinarily profitable health insurance company.
Yes, it
And
is.
their CEOs and the
Yeah.
top managers make millions.
Yeah,
They're pulling in money hand over fist
they are.
through
They
Medicare
are.
managed care plans.
They really are.
Money handed to them by the federal government.
By you. Yeah. Well, they really are. This takes us back to strategic decisions, right? Like that FDR and Churchill were faced with in the World War II, you know? You got the Russians and you got the Germans, and maybe you make a temporary
Analogy.
alliance with one of them, okay? So Anthem is Russia in this. They have, Hartford Healthcare has one economic interest, and that's to collect more money, okay? Anthem, at least nominally, has an interest in driving down price. I'm not disagreeing with anything that you said, but these are cards we've been dealt. And I would also stress that throughout our entire healthcare history, the U.S. has consistently, and you can disagree with it, and I do too, but the U.S. has consistently chosen to go with for-profit, private health insurance carriers. That's the system we have to work with, okay? That doesn't mean it's right for the long term, but as we're fighting a tactical battle like this one, like a contract dispute between the hospital and the carrier, I know which side I'm on, okay? I'm on the side of the carrier that's trying to get a slightly lower price. Is it low enough? No.
It's all going to go into the CEO's bonus next year.
No. Well, you know, I don't disagree with you.
And into the huge dividends and they pay, and the stock prices that go up.
Let me suggest that the speakers go on and we'll have a discussion
I'm
period
sorry.
afterwards.
Yeah.
I don't know,
Can't help
she's asking
myself.
It's
That's okay.
no, these are great points. You know, there are some guardrails on the health insurance companies that came into the ACA. They have to pay either 80 or 85% of the premium dollars out to the medical care companies. So I agree that the insurance companies are a problem, but most of the money that you pay for healthcare and most of the money you pay for your premium is going to pay high healthcare costs. So my focus during my tenure at the Office of Healthcare Advocate is on the high healthcare cost. That's the problem that is facing consumers, and that's the central problem. Part of the solution to the underlying problem of high healthcare costs is universal coverage. Folks talk about Medicare for all, folks talk about single payer. Those are all valid and tested methods, as we saw in the display over concerning the foreign countries. But the key part that all the other countries that are bopping along at half our price, the key part that every one of them has that we don't is universal coverage. Everybody is covered, okay? And that's very important, because if you're not covered, you don't go to the doctor until it's too late, and you come in and you are a very expensive patient. And so that is the least effective way to deliver healthcare, is when a system's not universal. So I'm interested in single payer, I'm interested in Medicare for all, we can talk about all those things, but the most important thing of all is to get to 100% coverage. I would also note that, interestingly enough, well, I was on the radio this morning and there was some talk about whether health care was a privilege or a right. That issue, you should know, as Connecticut citizens, had been decided in Connecticut. In one of the statutes that controls my office, 38A-1051, the legislature declared that healthcare is a human right. So that is public policy of this state, and we should make sure that we get to a place where that's real, because we saw the uninsured rate. If you don't have health insurance, it's hard to get health care. The last point I wanted to make is that there was a very strong effort to get to something that was similar to a true state single payer like system called Sustanet. It was a very strong effort that evaporated when the ACA passed. But this state does have a history, recent history, of trying to make some progress on these issues. So we've been talking about healthcare costs. I want to tell you folks about an initiative that I started recently called Connecticut Speaks Out on Healthcare Costs. It comes from my fundamental belief that, again, the central problem facing consumers, when you look at it from the system-wide level, is high healthcare costs. If we could get our costs down to an internationally competitive level, all of our problems would get better. The access would get better, obviously the monetary strain would get better. And so we are hosting a series of events around the state, including one that's going on actually right now down in New Haven, where we go through some slides about the international healthcare costs, but then we go right to the microphones and try to solicit stories from people like yourselves about your struggles paying for healthcare, and in particular, what are the financial pain points? Where are you really needing to slap leather? Is it the drugs? Is it your premium? Is it something else? Do you have medical debt that you're paying off? Where are the financial pain points for you? We're going to collect those stories and that information, and we have some surveys that you can fill out online. I also have a box of paper versions of those surveys. If anybody wants to fill one out before you go home tonight, I would appreciate it very much. We can input it into our online system, or you can go online and tell us your story about you or your family's problems paying for healthcare, and give us your information about the specifics of your struggle to pay for healthcare. We're going to roll all that information up and create one or more reports that we will then use in the next session of the General Assembly, which starts in February. We'll use with this governor and the next governor, and we'll also use it with industry leaders, because I'm strongly of the belief that ever since President Obama was elected, we've had an extended debate about healthcare. We've had a debate about how it's funded, where the money is coming from, exactly the mechanisms that the money moves through the system. But what we have not done is we have not had a mature, honest conversation about healthcare costs. And I know it's an ambitious thing, but I think that Connecticut can start to have that discussion. And it will involve contributions from folks like yourself. I don't mean just your ideas, but I mean thinking about what trade-offs are you willing to make. For instance, if you could have a lower premium, would you be willing to sign up for a plan with a narrower network? So for me, I live in the Hartford area. Would I be willing to pay a lower premium for a plan where I could only go to St. Francis instead of Hartford Hospital? Something of that nature. Would I be willing to if I could pay a lower premium, would I be willing to sign up for a plan where I was locked in for more than 1 year? I think it's a vulnerability of our system that it goes year to year. It gives if we were locked in to our carriers for longer periods of time, what would it do? It would give the carriers, they always talk about having patients get skin in the game. It would give the carriers skin in the game in your health. they'd be more willing, if they knew you were going to be their patient for 5 years or 3 years, they'd be more willing to do something like pay for a gym membership, right? Because they would know, I've got this client not just for 1 year. As it is now, if it's annual, it's almost like the Wall Street next quarter mentality, showing the profit so that we get the bonus. That's baked into their whole business model because you could be gone, or your company could be gone. So these are the types of trade-offs that I want the consumers of Connecticut to start to think about. Would you be willing, if you could get a lower premium, would you be willing to go with a plan that locked you in for more than 1 year? So everybody will have to be part of this conversation, including the insurance carriers. We have to deal with these people just the way we had to deal with the Russians during World War II. So that concludes the presentation. I hope I hit on most of the points you wanted to talk about, Jill. These are the numbers to either go on and find our Connecticut Speaks Out survey, tell your story online, or to call if your loved one needs assistance from this office. So thank you very much for your attention. Be happy to go to questions at this point.
I think a round of applause. And I'll call on people. I want to suggest that so that everyone can get a chance to talk, try to hold any comments to 2 minutes. Jill, when the time comes to gently tell people they're going on a little too long, if you could let us know, that would be great. So the floor's open. Yeah.
Yeah, I have a question about how healthcare cost is defined or what goes into it. When I get a statement from my insurance, I get how much is billed and what Medicaid pays and what my secondary insurance paid. And to give you one example, in hospital physical therapy that I was the patient that consisted walking from my room to the end of the corridor, walking up a few fake steps and back down to my room, and the bill said $975 for that one time, right? So is that part of the cost, or is part of the cost what Medicare actually paid for this one charge? And when I'm not having an insurance, then the doctor may charge me $375 for a visit, but if I have insurance, the insurance may pay $100 or whatever. So I'm very confused about the meaning of this discrepancy and the fact that each insurance pays differently, but if they negotiate, each private patient who doesn't have insurance get billed something differently, and they can negotiate with the provider. You see what I mean? So what is cost, really?
What is the cost? Well, first, I think you're asking about, like, when we're looking at the international cost comparisons and we're saying that the U.S. costs $10,000 per year for treatment. These are all estimates, that are made by, sophisticated people, but what they're trying to capture is the actual payment. And the actual bill, as you point out, is very different from the actual payment. And patient A may have a different price than patient B because they have different health insurance carriers and they've struck a different deal with the hospital. The U.S., if you had to describe the weakness of the U.S. healthcare system, and there are strengths, but the weakness of the U.S. healthcare system is complexity. It's complexity in the number of types of insurance we have. I have a dearly beloved cousin of mine who for many years had employer health care for himself and his family. Then he switched to a new job and they only covered him. So now he had to figure out how to cover his spouse and his children. At the end of the day, this was post-Obamacare, The kids got on the Medicaid expansion, and the mom had to buy her health insurance through the exchange. So now there's a family of 5 with 3 different insurance carriers. And you're pointing out that yes, the coverage is complex, but then the billing is esoteric and complex, and sometimes purposely so, right? To obfuscate. So I think, anyway, the international healthcare comparison costs are trying to capture what's actually paid. And how well they do that is up for debate.
So pay to the provider.
Right,
but
pay to the provider.
insurance- What the insurance costs is not included in there. The
No,
profits of the
you
insurance.
mean how much you pay in your insurance premium? Yes, that isn't included. So they're trying to capture how much how much do the providers receive, right? How much do they receive, which a big part of that is paid by the insurance companies through your premiums.
But what the person pays to the insurance company as a premium is not included. Is
Well,
that-
it's not double counted. It's not counted, when the care is purchased. I think they're trying to capture how much the care is purchased for, and that purchase price comes from your co-pays, and it comes from your insurance company, but your insurance company, that is where your premium is located, right? You've given your premium money to the insurance company, and then they pay it to the provider.
And put it in their own pocket. Is
Well,
that
they
included?
take part of it for their own pockets.
Is
yes.
that included in healthcare costs?
Yes, it is.
Okay. Because that would explain a lot about the differences between different countries.
Well, we have a
Yeah.
for-profit system. I mean, the issue we have is for-profit. In other places, it's not for-profit. It makes a very big difference.
Thank you.
There's a lot of different ways to run healthcare systems, and a lot of them have nonprofit elements, and a lot of them have for-profit elements. One takeaway I want you to think about is that for-profit or not, the other countries are generally, the other advanced, wealthy countries that are economic competitors are doing it for half the price. And so we know there's a lot of room for improvement. Part of that is, yes, the high costs of the administrative system. I will say that I'm guessing that 20% of our excess over the world is caused by the administrative need, caused by our decision as a nation to use these private insurance companies to have these billing structures on both sides. The providers have to have, one of my oldest friend is an orthopedic surgeon, and he has more insurance people than he does clinical people. All of that in a country like Japan doesn't need to exist because there's not this struggle between the biller trying to get more and the payer trying to pay less. So I'm thinking about 10% of the cost on the provider side is the administrative structure to try to bill correctly and get as much money as possible. And then 10% on the insurance side is where the insurers are trying to make sure that the providers are being honest, because there's a constant struggle between the two. And so right there, is a lot of cost. But it's tough to get that out. It's tough to eliminate that, and certainly difficult to do dramatically overnight. So I hope that this country will be able to come to some type of transition period, a glide path, so because you can't set these systems up overnight. It took 100 years for us to get where we are, and it might take us 5 years, 10 years to get out of it to a more rational system.
Other,
We've all heard that there are a lot of people who are opposed to the Affordable Health Care Act. And I was hoping you could help drill down about some of their objections, the legitimacy, or what are the possible corrections. In particular, what I don't understand is why premiums were going up for people who had health care insurance before. Did employers stop supplying health care? Or what were the factors that causing people who were buying their own insurance to have higher premiums? And the second is your statistics showed that Basically, what the ACA did was to expand Medicaid to a large part of the population who were formerly not considered the deserving poor. Why is it such a small percentage of the people who went to the exchanges? What's going wrong with the exchanges that they can't attract more people and make it a more positive, robust system?
Yeah, so with the first part of your question, I'm not sure I exactly understood. You were asking why were healthcare costs going up before Obamacare?
Why do people who had individual insurance, why are their premiums going up?
Why are they going up now?
Yes.
This year?
Since the ACA was passed.
Since the ACA. Well, certainly right now, this moment, this year, it's about to start, the 2018 plan year, there's big increases around the country. A lot of them are due to the uncertainty over the future of Obamacare. And, you know, the plans were, as it turned out wisely, predicting, for instance, that there was a risk of these cost-sharing subsidies going away. So they asked for higher premiums to accommodate that. So there's some uncertainty there. But the price of health care, and I mean the cost of a pill or the cost of an operation, right, has been increasing at more than the rate of inflation since before I was born. It has been, and it's unsustainable. So those cost growths have actually moderated slightly since Obamacare, but not enough to get on a sustainable track. Where we need to be, by the way, to get to an economically competitive status would be to hold our price constant for 15 years. That's what we need. Now that's a pretty amazing thing to think about, that you know, your healthcare costs would be the same now as it would be in 2032. That's what it would take for us to get from here to there. So I think that healthcare costs have moderated slightly since Obamacare. They're going up fast now. They were going up even faster before. And there's a variety of reasons for that.
He also asked why people were opposed to the Affordable Care Act.
Why are people opposed to the Affordable Care Act? They're, as best, and I have to do some anthropology here, right? Because it's not my tribe. I'm not from where those people are coming from. But what basically it is, and this has existed in the United States for a long time, and remember back to that slide about Germany, where Bismarck set up some limited health care because he wanted to take away a talking point from other politicians, the communists, right? They did that in the US also. The doctors were scared of corporate takeover of medicine. And they didn't want companies to be telling doctors how to practice. And they, at the same time, they were also in the 30s concerned about socialism. And the doctors went to the life insurance companies and said, you guys got to start offering some care to take away a talking point from these left-wingers. And so the insurance companies didn't want to do it at first, but they eventually said, okay, we'll help you to try to stem the communist, takeover of corporate America, including healthcare. We'll start these insurance companies. And that was a devil's bargain, it turned out in the end, and now we're stuck with, the Leviathan of the insurance companies.
Well, Ted, I can share one other thing. Like after working with over 6,000 people, I can tell you there's a good percentage of people who say, this is not going to work out for me. I don't think you can do anything to help me. And so then, we go through their information, and then they get a health care plan that they actually can afford, and they're surprised. So they said, well, what's the trick? How are you going to fool me? What's going to go wrong? I'm not going to be able to see anybody I want to. I said, let's go check. Let's go make sure your doctors are there. So we look and make sure their doctors are, but my medicines won't be covered. Let's go look. So we look and make sure of that too. I think there's a distrust that if somehow I'm getting something I can afford, it's a trick somehow. And like the thing that's troublesome right now is that, the subsidies or the part that the government is paying for could be taken away. That's the part that's making it affordable.
But of the 6,000 people you've helped, how many did you get onto Husky and how many did you get insurance-free exchange?
Personally, again, I'm covering Litchfield County, Columbia County, Dutchess County. I would say probably 15 to 20%. I'm not as high. So if you go in other places, you're going to have higher numbers. Ours was-
15, 20% more up to the exchanges?
No, 15, 20% were for Medicaid. Those were when I ran someone's numbers, they qualified for Medicaid, or their children qualified, or part of their family. So I wasn't discerning somebody who, the whole family or just a partial family. Because you can have your children covered on Husky, but the rest of your family might not be. So anecdotally, I can tell you that I can count on one hand the people who were displeased with the outcomes of the insurance they got.
There's a question back here.
How much does for-profit hospitals and healthcare providers, how much has that been driving this up?
Stand up. You stand up. Oh, you got it? Okay.
Yeah, he was asking how much for-profit medicine is driving the equation, and I'd say, an awful lot. But remember, when your premium goes up, some of it goes to the insurance companies, and you can feel angry at them, but most of it is going to the providers. And
I was a kid, most of the hospitals were nonprofit.
all the hospitals in Connecticut still are nonprofit.
Shared hospitals.
It is
No,
nonprofit.
it just flipped back.
It was for-profit.
It was for-profit briefly.
Danbury Hospital's for-profit.
No, there's no for-profit hospital in Connecticut. But that doesn't matter because the for-profit versus not-for-profit, they act the same. So it really is not an important distinction anymore if it ever was. Phil?
How much do you think of the Medicare medical costs and insurance costs are because of the litigious nature? Because that's something that isn't being talked about.
Yeah.
There's a whole bit about how much medications are costing. There's the whole piece about how much doctors are costing. But there's not the whole bit about how much those two companies are needing to pay in order to pay off lawsuits.
Yeah. So that is a great point that people talk about all the time. What's the cost of the defensive medicine and the medical malpractice? It's not zero, but it's a low percentage of our costs. I'd say studies have shown it's something like 3% of the medical dollar. So you could end the right to sue doctors, and we'd still have 97% of the costs here. Unfortunately, that's not going to get us. There's nothing wrong with it from the cost perspective. You have to talk about it from the political perspective. Are you actually willing to, if your child is hurt during a surgery, to give up the right to sue somebody that made an inexcusable error? So there's that aspect. But I'm looking at it just from the cost aspect. It might be worthwhile, but you're going to have to do something else beyond that to solve the problem.
Yeah, because I think in the news it doesn't seem that way, right?
Excuse me?
In the news it doesn't seem that way.
No, that's
You only
right.
hear about the big lawsuits that happen.
Yeah.
You don't hear that it really is a insignificant chunk of the whole overall money.
No, I know that message does not get out, and it's a strong talking point that is constantly used.
Well, weren't you talking about more of the cost for just the disparity in a procedure being done in Illinois could be, $2,000. You go to New York and it's $20,000.
So this is a good point that Janet's bringing up. I don't want to appear that I am dumping on the American healthcare system and saying that it can't take care of people at an adequate cost or an internationally competitive cost, because American healthcare, we know healthcare can be delivered at a better cost because other countries do it. You know who else can deliver healthcare at an internationally competitive price? Americans can. Because if you look at the amount of price variation, for instance, if you take, I saw a slide just recently that had 4 hospitals in St. Louis, the price for a knee replacement at 4 hospitals in St. Louis. The highest one cost $87,000, the lowest one cost $25,000. I know from my own research and reading that that $25,000 hospital, that is the international price. Okay, so there's a hospital in St. Louis that is probably not losing money, and the people there are feeding their families, and the hospital president probably gets paid pretty darn well, and he's delivering a knee replacement at the same cost as occurs in Germany. When you look consistently across the US healthcare prices, if you look at the 75th percentile of US prices and the 25th percentile of US prices, consistently I find that the international price, the half US cost price, is at the 25th percentile. So what that means is that 1/4 of the providers in the US already are providing care at half the overall price. That means it can be done.
Well,
right?
it can be done because we're doing it with Medicare too.
Excuse me?
We're succeeding with Medicare because we have, negotiated rates with Medicare. It shows it works.
And Medicaid actually, I know you're interested in the situation in Connecticut. In terms of cost control, there is a bright spot in Connecticut. The Medicaid the changes that went in about 7 years ago, it took away Medicare from the managed care insurance companies and brought it much more under state control. And we have had, I don't know if it's literally the lowest price growth in the U.S. in Medicaid, but we're darn close to it. I mean, only maybe one state is doing better than us. Medicaid has really controlled costs very well in this state, and frankly, Governor Malloy deserves a heck of a hand for that. So cost control is possible. There's bright spots to be had. You don't have to think we got to have a Japanese system. No, we just got to figure out what the $87,000 hospital is doing differently from the $25,000 hospital. And there's some pain, right, in getting, because that $87,000 is income to somebody, right? And they're going to fight to protect it.
What is the difference between those 2 hospitals, say, in St. Louis?
What is the difference?
What is the difference? Why does one hospital get away with charging more? Is it location?
Well, there may be, it's probably just a corporate approach. And one hospital is, for instance, I spoke somewhat disparagingly of Yale earlier. Yale is that type of hospital. Okay? Yale is going to have very high prices. They would tell you they're delivering better care, right? Then when you get underneath that, you would find that that's actually probably not the case. But what they are doing is they're just running a much more expensive operation, right? The doctors probably get paid a bit more, and they're probably taking more out as a corporation at the end of the day. They just have a higher running, theirs is a race car versus, something more economical.
I'm just wondering, Ted, excuse me for
Yeah.
just a second, I'm sorry. I'm just wondering if, and I'm just being the devil's advocate here, but is that expensive hospital in St. Louis, do they have orthopedic surgeons who do that knee replacement, who've done it many times, versus the other hospital that only charges $25,000? Do they have an orthopedic surgeon who only does knee replacements 4 times a year?
Yeah.
Because I know that the more a physician, especially a surgeon.
So I obviously I don't know about this particular
Yeah,
hospital
but
in
in
St.
my mind,
Louis,
I'm wondering.
but generally speaking, this question has been studied by healthcare economists quite a bit, and there is actually no correlation. Well, there is, and I'll go into it in a moment. There is little correlation between the quality of the cost and the charged amount. And the correlation that does exist tends to show that the cheaper care is better.
Interesting.
Yeah. So,
Yeah,
I'll just say who I am. I'm Anna Tamel, and I work in a Medicaid clinic in Waterbury. One of the things about Yale is that it's the only place I can send my Medicaid patients to for many of the specialty care that they need. So nobody with Medicaid in Waterbury can get neurosurgery or neurology or decent orthopedic surgery or dermatology or advanced pulmonology. The whole state is flooding to the clinics at UConn or Yale. That's why they're more expensive, because that care is very poorly compensated.
Medicaid.
I just thought, the Medicaid.
Yes.
I just thought I'd
Yeah.
mention that. So I'm fond of Yale. They take care of my patients when nobody else in Waterbury will.
Yeah, that's great, and I'm not saying it's a low quality operation in terms of the healthcare they deliver. I'm saying that they're run aggressively as a financial machine, and that is separate from the clinical side of it. Yes.
I do think quality of care is part of the issue here. I have a daughter with specialized eye concerns. We looked at one point to put her on Affordable Care Act, as my son is, and as soon as we started making calls to her physician, her specialized physician, oh no, we don't take Affordable Care Act patients. And I've run into that with orthopedics, with my daughter's eye issue. We're breaking into a two-tier system here in terms of quality of care.
My comment? Okay. Other questions? Substitute, or, not just questions, comments.
Could I ask a question about your experience with doctors, since I've announced I am one? What do you think the state of affairs are vis-a-vis supply of doctors in Connecticut? Is it something that's stable, or what's happening?
So I'm still actually exploring that question. I when I first took this job in February, was pretty strongly of the impression that this state needed more primary care physicians. And some smart people that I work with have caused me to relook at that. I think at the end of the day, we probably do need some more primary care doctors.
I can tell you a little bit about what's going on.
Could we ask the audience if they feel that they've had a hard time or an easy time finding a good doctor? Why don't we ask them?
Specifically primary care or special?
I would ask about primary care because that's the kind I am.
I look for a new one about every year when we renegotiate our health insurance with the company I work at. Frequently, I have to change positions.
Well, I can tell you, Sharon Hospital has actually undertaken a program to bring medical students to Sharon Hospital that actually did rotations amongst the clinics and some of the nursing homes here. So if it was a student who was interested in geriatrics, they did a rotation to a bunch of the different facilities here. So they're working with doctors, with DOs. I think they were working with NPs and PAs too. So I think nurse practitioners and physician assistants. So they were actually bringing in folks who are filling those primary care jobs, because a lot of them are nurse practitioners and PAs and DOs. So they're actually creating a program to bring more med students here. And then they have a program, if they decide to stay, that they get their costs taken care of. So they're also providing housing.
Janet?
That was this year, this past year.
Just how long ago?
This past year.
Before they became the nonprofit again?
Yes, Peter Cordeau is the CEO over there, and he was the one who was instrumental in getting that going again. Yeah, and it was very successful. I mean, it was, if you went into any of the primary care practices around, which we were, there were med students trailing the doctors all over the place. And it brought a different energy to an office. I mean, when you have a medical student participating, it definitely brings like a different viewpoint, and and they were all interested in looking at staying in Litchfield County, which
How
I thought
many
was fantastic.
primary care physicians are there at Sharon Hospital?
As hospitalists or associated with the hospital?
As primary care?
I don't know that number offhand. There's been more people retiring, but there's also more people, there's more affiliations going on. They're hiring more hospitalists. So hospitalist is one that's employed by the hospital. And there's a bit of a trend of that going on too, where more physicians are willing to be employees of the hospital. So they can just really focus on the care. I see that as a positive. I don't know how you feel about it, Ted.
Yeah, one other thing just to note about that is the state now has 3 medical schools. The Quinnipiac Medical School just graduated, I think, in June, its first class. I mention that only because they're strongly focusing on family practice and primary care practice there. I hope that some of those students wind up staying in the state, but at least that's a positive development in terms of primary care physician supply for the state.
Well, there are programs that allow rural, if you choose a rural practice, that you'll have debt forgiven too. So there's a lot of those kind of programs happening also.
Ella?
Is there an initiative in the state, as there is in California, to try to look at the cost of drugs and get them lower?
Yeah, there is. There's a body called the Governor's Healthcare Cabinet, which I'm a member of, and right now it's being led out of Nancy Wyman's office, the Lieutenant Governor's office, and right now we're right in the midst of developing some policy proposals that we hope to bring to the next session of the General Assembly. You raise the California laws. There's other laws that have either been passed or come close to being passed around the country. So yeah, I would hope that we're going to have some recommendations in time for the next session of the General Assembly, and also I think there'll be an upcoming opportunity when there's a change in administrations. As you know, Governor Malloy has said he's not going to move for re-election, so there's going to be a new governor of whatever party, and I think there might be an opportunity there to pass some reform bills that would certainly include some type of pharmaceutical focus. Jill?
I just wanted to go back to the observation that Jane made about the fact that even if there are doctors in Connecticut in our area, you may have to change, as she says, every year because they won't accept what you can pay, what your insurance will pay. Just a thought.
No, it's a problem that does go back to what I just am not real sure why the insurers lock on to this annual policy, because it's difficult for them too. They have to make a lot of switches every year too. Why is it not to their advantage to go to a 3-year cycle? And then at least when you switch your insurance plan, you might still have to switch your primary care, but at least it would be every 3 years instead of every single year.
I'd like to ask both of you if you took the objectives that have been suggested here for Connecticut, making healthcare universal and lowering prices to something more approaching the international standard or the bottom of the American share. What are the 2 or 3 things that you would think of as the most important over, not the next year, but say the next 5 years for us to try to accomplish here in Connecticut?
So I certainly think that some type of at least transparency on the drug costs. I serve on this committee with this woman who represents the pharmacists, the independent pharmacists, not CVS, but independent pharmacists like the one over in Salisbury or something. And man, they don't understand at all what they're going to get paid for every transaction until they get the check at the end of the month. So even there's just a lack of transparency. Some of you folks may have read the article. I think it became a book by Steve Brill recently about the difference between what they call the charge master of the hospital and what is actually paid. The lack of transparency really, that to me seems like a common sense thing, seems like low-hanging fruit. So I look to those 2 areas. The other area that I think we can make some progress on is these high deductibles. Many of you folks might be on high deductible plans. That's when you have to pay a lot out of pocket before the insurance even kicks in. So there's a lot of ways that those work that just don't even make sense. They tell you that you should be on a high deductible plan because you need skin in the game, right? You're going to wastefully go to the doctor all the time and drive the healthcare costs up. So you have to pay first. That way you'll calm down and not go see the doctor so much. Well, that's the idea, right? You need skin in the game. Well, how come then you have to pay for something that you can't shop for? Like when the ambulance comes and gets you, you don't get a chance to say, oh, don't send ambulance A. Up here, it's going to be, the volunteers anyway, and they're going to bill whatever they can. You don't get to shop for that. So if the idea of the high deductible is for you to have skin in the game, and you're not allowed to shop, that's ridiculous. Here's something else that's ridiculous. When you are, say you're on Cigna, and you're trying to work off your deductible, and you have a high bill, $1,000 bill that you need to pay, or a drug you need to buy, $1,000 drug that you need to buy. Well, you can go to the pharmacy and give them your Cigna card, and they will charge you $1,000 for the drug. What if you go on the internet and you find that the pharmacy, Walmart, let's say, what if you go on the internet and find that you can walk into Walmart and buy that drug for $500? Okay? Well, if you do that, and Walmart's not in Cigna's network, that's not going to count against your deductible. So now you've done what they've asked you to do. You've been the smart shopper. You've found the cheaper drug, and it doesn't count against your deductible because it's out of network. Does that make sense?
Crazy.
There's a lot in this high deductible thing, that a lot of improvements we can make. Let's take another one on the high deductibles. And this happened to me. I'm bopping along, I'm in a high deductible plan, I'm in a year where I'm having a lot of health expenses, boom, I hit the deductible, now I'm in gravy, right? Now everything's covered. Well, then I switched jobs, and I switched to a new high deductible, and it's like August. Okay? So what's the deal? Do I get any credit for the idea is you have skin in the game. Well, I showed skin in the game. I just paid $14,000 to another company. I put skin in the game. Now, oh no, now you have another deductible, sir, that you need to work off with us. Well, okay, but it's August in the year. It's at least prorated, isn't it? No, it's not. It's not even prorated. So the way they've structured these high deductible plans are filled with these logical inconsistencies that I think you could get a bill through a legislature and just say, that's just stupid. Right? And so those are some of the areas that I would look at. I don't know what Janet's list is.
Well, it's, there's two things. I mean, first of all, people get very anxious when they talk about Medicaid. Medicaid is always seen as a handout. But the thing is, we all pay for it. So I think, especially in the state of Connecticut, Medicaid has changed people's lives. I worked with a guy who lived in a tent. He lived in a tent. His health was terrible. And we signed him up for health care. He started seeing the doctor. I saw this guy. First of all, he's living in a house now, and he looks like a human being. He looks like a healthy human being because he's been to the doctor, he's been to the dentist, because he's covered. He never had that. I worked with a client who was 63, was born and had never been to the doctor, and realized that they're probably going to need health insurance. So I mean, that's insane. Like her whole life, she never had health insurance, never went to the doctor or a dentist. That's crazy. So, I think that we need to change our attitude, and I know that some of the folks out of Yale are talking about having Connecticut go to Medicare for all. It's Medicaid or Medicare E for everybody. Because people talk about Medicare, I'm so excited to be on Medicare. I can't wait till I can be on Medicare. No one says that about Medicaid. They're not very different, but the attitudes towards them are. So if there's Medicaid E and we could all be on it, I don't think there'll be anybody who's like, oh, boo for Medicare E. That's crazy. But I think what we can do now is ask the questions. I went to a physical therapist, and they said, oh, it's going to be $100 a session. And I said, wow, that seems kind of steep. I have insurance. And she says, yes, you have a deductible. Damn it. Foiled again. So I said, well, what are my options? And she said, you can pay $65 if you pay out of pocket. Well, I'm paying out of pocket either way. So I said, that sounds good, I'll do that. So how many people asked that question? I sat there and watched people do this, and they said, yours is going to be $100. And they said, okay. And I wanted to go, hey, ask her about private pay. That wasn't my place. So I think I might do that. I might have a placard that just said, ask about private pay. But I got to figure out how to not get in trouble. But I think, I know Ted talked about, the medications. You can get medications much cheaper. There's 100 different ways to do it. If you can't afford your medicines and you need to get on a patient assistance program, it is doable. It's not the easiest thing, but we have people who know how to do that. So until we get to universal health care, which I really hope to God we do, because people need healthcare, as we said, is a right, then we need to figure out other ways to get the care we can afford. So I would encourage us all to work together. Jane, someone, the Office of the Healthcare Advocate, we can help you. So there's no excuse for anybody in Litchfield County, Dutchess, or Columbia County not to have what they need, because we have it here.
If I can just make one comment about Medicare, and I worked in Medicare, CMS, the Center for Medicare and Medicaid Services, for several years, and it's a great program, but it's pretty freaking complicated too. I mean, let's say you're on traditional Medicare. First, younger folks don't know, you have to pay a premium, right? It's not free. Secondly, you're on traditional Medicaid, you got your red, white, and blue card, that's terrific, but it's not free, right? And you have all these co-pays, so what are you gonna do? You're gonna buy what's called a Medigap policy. So now you got your AARP, United Healthcare card, and your Medicare card, right? This is great, but guess what? None of that covers your drugs. So now you have to go get your Medicare Part D drug. Now you're looking like a card dealer down, when you go to the healthcare. Which one is it? I don't know. You're on the great Medicare for All program. So Medicare is a good program, and Medicare for All could be a good option, but it's complex. It's very complex. And also, another thing that you should know about Medicare is, especially if you're a person who thinks insurance companies are really bad and evil, well, guess what? Guess who runs Medicare? Insurance companies run Medicare. And if you doubt it, think of this. Medicare, where I was a senior official, and I know, Medicare has 6,100 employees, 6,100. Those 6,100 people administer $1 trillion, okay? They cover something approaching 80 million folks. United Healthcare, which by some measures is the largest insurance company, they don't cover 80 million folks. But how many employees do they have? Does anybody in the audience know how many employees United Healthcare has? 210 million. Okay? So each man.
Say that again.
Excuse me, 210,000. Excuse me.
That's bad enough.
210 million. That's a lot. That is a lot. That's a 210,000. 210,000 for a pro, and maybe they manage probably like somewhere between 100 and 200 billion dollars. So something like less than a fifth of what 6,100 federal employees are managing. Each one of those federal employees is responsible for, let's say, $165 million of spend. They can't do that. They don't do that. You know who they hire? Insurance companies. They have federal contractors that run insurance, that run the entire Medicare program. Just the same way that, the Navy doesn't build subs, right? Electric Boat builds subs. It's the same thing with Medicare. Medicare is run by insurance companies, and that's why in May 2017, Mark Bertolini, who was the CEO of Aetna, on their earnings call said, I want to have a conversation about single payer and about Medicare for all. And he specifically said, because we at Aetna are in that business, we at Aetna paid the first ever Medicare claim back in 1965 for $543 to Harvard Hospital. And what Mark was saying was that he's not scared of Medicare for all because Aetna is a Medicare contractor right now. And hundreds of other companies are Medicare contractors. You don't hear of them, but they're large, important companies. You don't hear of them because they only have one customer, the federal government, so you don't need to hear about them. But to the extent that you are a fan of Medicare for All, be a fan, and I'm a fan, and to the extent that you are an opponent of insurance companies, think about it. When you're voting for Medicare for All, you're voting for insurance companies. Just the way it is.
We gotta keep working on it.
So this has been tremendously informative. It's time for us to wrap up. Is there one question that somebody is desperate to ask before we close? Okay.
Who among us is going to finish the cookies and treats?
Your premiums will go up 50%. So I'd like to thank our speakers so much. Above and beyond what you expected in the circumstances. And I think there's a gentleman here who wants to make an announcement.
Yeah, so I'm Michael, I represent Protector Care Connecticut. We're a separate organization from the people who posted this, but we are fighting to defend the ACA and fight for universal health care. So if you're interested, please sign up, and many of you signed up already, so thank you. But if you're interested, please see me and sign up to our campaign.
Thank you so much.
Hey, good, thanks for asking.
Richard, thank you. This will be on Richard's website.
On the Cornwall website.
Cornwall website, AKA the Cornwall website.
Nice to meet you. Nice to